welcome to this Blackpool Teaching Hospital's ultrasound video lecture. My name's Simon Hayward and I'm going to be talking about lung ultrasound in relation to COVID-19. So today we're going to cover a little bit of background about what's been going on with lung ultrasound and COVID-19 recently, some of the pathophysiology, some of the signs that you see with lung ultrasound, and then also how those signs combine to form patterns when you're doing an ultrasound scan, how we can use it to monitor a patient's condition, and then perhaps some information about how lung ultrasound can inform the management of patients who are suffering with COVID-19. So a little bit of background. Since COVID-19 came onto the scene, there's been a huge amount of information. Lung ultrasound has become very, very topical and very popular. And so has the information and the research that's been created around it. So at the time of recording, there were well over 150 research publications about lung ultrasound and COVID-19 specifically. When I wrote a narrative review back in early 2020, we included 11 papers in that narrative review. So you can see that it's jumped from 11 to 150 in a matter of about 6-7 months. We published that online in April, and since then we've had over 50 citations in the literature. So this is a huge area of expansion and a massive amount of interest in lung ultrasound. So what about the pathophysiology? Still a bit of a work in progress, but there seems to be some more and more specific information that's coming out. So it would seem to be a pulmonary capillary endothelial cell infiltration. So the virus affects the endothelial cells of the pulmonary capillaries and to some extent the alveolar endothelium as well. You get a diffuse thickening of the alveolar wall. That causes airspace infiltration by pulmonary edema. So the edema starts to infiltrate into the alveolar air sacs. And then there's this additional process of microthrombi forming in the capillaries. So you have an ischemic process happening as well. All of these lead to hypoperfusion and hypoventilation at different points in the lung. And as you would expect, a huge amount of VQ mismatching throughout the lung. Similar in parts of the process in COVID-19 to acute lung injury and ARDS. Later on in the disease process with COVID-19, it certainly does start to look a lot more like an ARDS type picture in the patients. And as that process progresses, there is gradual and then significant reduction in the compliance of the lung tissue. So in picture format, we have the capillaries across the bottom of the screen with the red blood cells. The capillary endothelium, increased gaps between those cells cause a thickening of the airway spaces and walls. You get a permeability of pulmonary edema into the alveolar sacs themselves, like I mentioned. And then on top of everything, in the right-hand corner of that image, you get pulmonary thrombus. So there's a huge cascade of processes that go on and that basically massively influence the body's ability to get oxygen in to the bloodstream and CO2 out as well. So how does this look under lung ultrasound? So you have the development of an irregular pleura. So the two pleural layers, the parietal and visceral, are usually really quite smooth. Not perfect, but quite smooth. And this is massively interrupted probably with very small, tiny irregularities at the pleural layers with COVID-19. You get B-lines being created. You have small peripheral consolidations, often heard as subpleural, but the literature is leaning towards small peripheral consolidations, which makes it great to be scanned by ultrasound, being a surface imaging technique. You get what's called C-lines. So these are comet tail artifacts, just like B-lines, but these don't necessarily come from the pleura, whereas B-lines have to originate from an intact pleura. C-lines don't, and they tend to come off areas of consolidation. And then you get much larger consolidations themselves developing. And in some cases, small pleural effusions, although that doesn't seem to be a huge component of the COVID-19 disease process. So what we want to see is lots of lung sliding and A-lines. That's what we hope to see in these patients, and as they recover and as they perhaps are admitted to hospital, we would love that they remain with a relatively normal looking lung presentation under ultrasound. However, most of the time you get significant B-lines, so you start to see them increase in frequency, increase in location, and increase in density. So the image on the right, you can see that there's just tiny irregularities in the pleural line, and so that is causing some degree of interstitial syndrome and B-line creation. As it progresses, you start to see an increase in B-lines. You start to see these little tiny peripheral consolidations. And then from those consolidations, you can see even stronger comet tail artifacts that, because they're not coming from the pleura, artificially B-lines, so are termed C-lines. But you get a mixture. With that video on the right, you can see there's a mixture of B-lines from the pleura and then C-lines from the peripheral consolidation. As COVID-19 progresses, you start to see an increase in the size of the consolidations to the point that they start to take over large proportions of each lobe, particularly in the dependent regions, and to the point where they take over the whole lobe, so they become completely translobar. And at this point, the patient is usually quite critically unwell. So those were the signs. So what are the typical patterns that we see with COVID-19 under lung ultrasound? You start to see diffuse bilateral presentation. So it affects both of the lungs, and it tends to affect the whole lung to some degree. There is a little bit of increase in the dependent zones first, but typically you can see quite affected areas in the upper regions. So it affects the whole lung in a bilateral presentation. However, it doesn't seem to affect all areas of the lung quite in the same way. So yes, you get a peripheral presentation, so it does seem to affect the peripheries of the lungs more, but in an irregular and homogeneous pattern. So you might find that there are areas of normal lung quite close to areas of affected lung, and then immediately next to that again, normal lung. So there's this homogeneous presentation. As the disease process progresses, there's a steady increase in the number and the distribution of B-lines. So the B-lines become more common throughout the lung. And as the B-lines increase, so do the C-lines, because you start to get more and more of these peripheral consolidations to the point where they start to blend together. In some of the literature from China, you start to hear what's termed the waterfall sign, and the literature from Italy tends to talk about the light beam. So basically this is this very strong coalescent B lines and or C line presentation coming from the pleural level or the subpleural consolidations. Like I mentioned, there is a slight preference towards the dependent regions, but it does affect everywhere. However, more and more the upper areas, so the non-dependent regions, start to become involved. And then, as I've mentioned on the previous slides, the consolidations do start to get quite large and affect the whole lobe. So how can we use lung ultrasound to monitor our patients with COVID-19? You can use the blue protocol from Liechtenstein that we're taught in the FUSIC modules, so 6 locations. But if you're perhaps doing more of a monitoring role and you want to get a better picture of how the lung is, considering this disease doesn't affect it in a homogeneous way, then maybe more locations could be useful. So that's where you could start to bring in the lung ultrasound score. So 12 locations, 6 on each hemithorax. And there is a separate video on the lung ultrasound score and how to use that. With whatever technique for monitoring you use, there's a certain degree of consistency. So perhaps timing, particular time of day, or on a regular occasions, certain timescales would be useful, as would the technique with what the machine settings and probe you use and the anatomical location for a patient on the patient themselves. So just to keep that consistency so that you're getting to understand that there is a change, then it is actually potentially a relevant change. And also, this patient is suffering from COVID-19, but that may not be the reason that they have significant respiratory symptoms, or if their symptoms worsen or improve, it may be due to the development or resolution of other pathology. So just because somebody has COVID-19, it doesn't mean to say that they won't get pneumothorax or pneumonia or pleural effusion. So definitely monitoring those patients regularly to make sure it's still the case that the COVID-19 is the most prolific pathology that's affecting the patient, but to keep an eye out for other potential differentials of pathology involvement as well. And also, if you can't find anything that seems to be affecting the patient, but they're particularly unwell or have deteriorated, then again, differentials of raising the suspicion of a pulmonary embolism, which is, we know, can be a high proportion of patients with COVID-19. So again, flagging that up to the team as a whole as a potential differential. So what about management? So monitoring that I previously mentioned, you can use to keep an eye on whether the patient's condition and pathology is deteriorating, or hopefully definitely showing some signs of improvement. So the images that you've seen before, going from A lines to B lines to increased B lines and C lines with irregular pleurs throughout, through to a consolidation in that right-hand graphic, would dictate that that's a deterioration in the condition and the aeration of the lung. We can use that monitoring to make decisions about how we want to manage the patient. And going back the other way, monitor improvement. So are they responding to the treatments that we are instigating on the patient? You can also use it to identify recruitable consolidations. So like I've said before about other pathologies, maybe some of these consolidations are or do have the potential to be recruited, and it would be good to use ultrasound to identify those or see how they respond to recruitment, either through recruitment maneuvers, PEEP titration, and prone positioning or side lying with regards to trying to increase the expansion and aeration of any particular consolidations identified. And the Intensive Care Society, very early on in the pandemic, created a flow diagram, which I'm just going to go through with you now. So you use your 6 zones, 3 on each side, though this can be increased to 6 each side if you so wish for the lung ultrasound score. But you're wanting to identify what pathology you can see with lung ultrasound. So hopefully, like I mentioned before, you want to have completely normal lung pathology, or at least as normal as lung ultrasound is going to give you. However, if you see abnormal and you start to see significant B lines and consolidations, then potentially you have a couple of options with regards to management. So you want to identify a pattern, and there's 2 phenotypes that have been mentioned in the literature. Now these are quite simplistic, and like most disease processes, it's going to be more of a spectrum. But if you happen to identify more of a diffuse B-line pattern throughout the patient, then these are the ones that would possibly respond to PEEP quite well if they're mechanically ventilated. Or, as is happening more and more, they are PEEP responders, but it's used non-invasively by CPAP. So these are the ones that if they're having a deterioration, then maybe certainly benefit from non-invasive ventilation, and particularly CPAP. The other pattern, as the B lines increase and start to develop consolidations and areas of atelectasis, and these are the patients that might be more responsive to positional changes, side lying, if that's all you can do, or even prone. But then again, you can use the lung ultrasound to monitor how the patient's responding to both of these techniques. You assess for progression or resolution. So is there a progression? Is it worsening? Or is there a resolution as they're heading back towards less and less B lines, or ideally back to A lines? So this section is very similar to the diagram I showed before of the deterioration or the improvement. So you can use it in that monitoring tool to make judgments as to whether the management can stay the same or needs to change. So in conclusion, COVID-19 with lung ultrasound has a distinctive presentation. So look out for those particular signs that I've mentioned, and then how those lung ultrasound signs fit into patterns as the disease progresses. You can use the lung ultrasound with the lung ultrasound score as a way to monitor the deterioration or improvement, and then use those changes to guide a few treatments, whether that's the PEEP or the prone positioning or any other treatment modalities that deem relevant or indicated at the time. It can be quite useful to make sure that we're not just, because we may not just be dealing with COVID-19, there's no reason why other pathologies might start to develop, particularly in a critical care population. And most importantly, giving you as a clinician the confidence to make some decisions about instigating a treatment, potentially leaving the management plan as it is, or removing treatments that may not be beneficial anymore because they have hopefully been effective. So in summary, just went through a little bit of the background about what's been happening with the research around lung ultrasound and COVID-19. Touched on a little bit of a quick update on the pathophysiology of the process and why it's affecting the lungs and how it's affecting. Talked about some of the signs of COVID-19. Some of them aren't specific to COVID-19 and may be similar to other pathological processes. But when you combine those signs into certain patterns, then that does become quite distinctive, and very few other pathologies present in those kinds of ways. How to use lung ultrasound as a monitoring tool, either using your 6 points or 12 points and monitoring that improvement or deterioration, and then using that information to make decisions about the management. I hope you found this beneficial. If you have any questions, by all means get in contact with me, and thank you for listening.